So I guess going on with the snake theme at the moment. Pressing things. The two common elapid snakes that we see here in Australia are tiger snakes and brown snakes. In Victoria, for some reason, we tend to more commonly encounter tiger snakes. We know that their venom contains a multitude of proteins, which leads to a bunch of sort of syndromes, such as a neurotoxicity, a myotoxicity, and a coagulopathy. And it's this coagulopathy that I'm going to be talking about today. So in a study looking at the clinical features of snake envenomation in Melbourne, about 4.8% of dogs had clinical signs of a coagulopathy. This is just mucous membrane, bleeding from the mucous membranes, hematomesis, melena, and then in the literature, the reports of extradural hematomas, suspected intracranial hemorrhage, and of course pulmonary hemorrhage as well. Now, in contrast to this, we know that about 69 to 73% of dogs actually have a coagulopathy as detectable on blood work. So this can range from prolongations in PT, APTT, and ACT, even viscoelastic changes as well. We know this occurs in a dose-dependent fashion, so if there is a coagulopathy, we can be fairly confident that dog has had a lethal dose of venom. In fact, we exploit this when we're trying to figure out whether or not the dog has been bitten by a snake. So when it goes bad, it can go bad. So as we know, there's the Leong et al. Group who looked at a bunch of dogs that had been envenomed by brown snakes, and it was a case series, and in their case series of dogs that had pulmonary hemorrhage, there was a 30% survival rate. So that's different to the 75 to about 87% survival rate as touted by the Mertstrom paper or the snake map data. So that's about 2 out of 3 dogs that can die. So what is it that causes this coagulopathy? It's been dubbed venom-induced consumption coagulopathy, or VIC, previously known as a procoagulant coagulopathy, defibrillation coagulopathy, and incorrectly as disseminated intravascular coagulation. As the name suggests, it's a procoagulant coagulopathy, and it's specific to snake envenomation. There are different types of VIC that have been identified, and they all act on different parts of the coagulation system. The main ones that are present are prothrombin activators, factor 10 activators, factor 5 activators, and thrombin-like activators. So our elapid snakes have a prothrombin activator. Remember that prothrombinase is made up of that factor 10 and factor 5 complex. And so brown snake venom, or the Sutarin C venom, contains a activated factor 10 and 5 complex that's ready-made. Whereas our tiger snakes only contain, the notocharin D venom contains a activated factor 10 only, which requires endogenous factor 5. Now going back to our physiology, prothrombinase breaks down or activates prothrombin into thrombin to produce a large burst down in the propagation phase. And this allows fibrinogen to then be converted into fibrin for a clot formation. Now, once you've got this big burst of thrombin, remember that thrombin also has a bunch of other effects, particularly up in the amplification phase of the cell-based model. So thrombin's responsible for activating a few other factors, factors 8 and factors 5. So factor 8 makes up that 10A's complex, which then activates more factor 10. And factor 5 goes on to be part of the prothrombinase complex. So it's this vicious cycle of upregulation of this pathway, which then allows more and more consumption of factors as well. So in 2010, the ISVISTA group looked at the factor deficiencies in people with VIC. And what they found was that most people had absent fibrinogen, low to absent factor 5 and 8, and partial depletions in factors 2 and 10. So there was a consistent change, and although there was rapid decline in the first 1 to 2 hours, there was predictable recovery of factors as well. So in about 12 hours, 50% of patients had normal factor 5. By 15 hours, 50% of patients had normal factor 8, and by 24 hours, 50% of patients had normal fibrinogen. So what about dogs? Well, we know there's a clinical coagulopathy. We know there's a coagulopathy as detectable on blood work, but what are the actual intricacies of the factor changes and what's recovery like in our patients? And I guess that's the gap, and that's where my study comes into play. Just giving up on that. The overarching aim of my study was to characterize VIC in dogs. So I wanted to have a look at the factor changes that occur initially on presentation, and then follow the changes that occurred during hospitalization and recovery. My hypothesis was that initial coagulation factor activity in tiger, snake, and venom dogs would be significantly different to a control group, and then return to control levels 24 hours after anti-venom administration. So I had ethics approval to enroll 40 dogs. My inclusion criteria was dogs of any age, breed, sex greater than 10 kilos, with a history and clinical signs suggestive of snake envenomation. So that was your collapse in the park or at home, with your pre-paralytic signs such as vomiting, diarrhea, collapse, and an apparent recovery, or progressive paralysis or paresis, and your typical cranial nerve deficits as well. Then all dogs had to fulfill at least one of the following criteria, similar to the snake map, and that they had to have a positive snake venom detection kit, have a CK greater than 1,000, have a prolonged APTT, or seen physically bitten by a snake. All dogs had to be treated with antivenom and hospitalized in the ICU. Then we went on to exclude dogs that had been previously treated with antivenom, were anemic, or were negative for tiger snake venom on post-collection analysis. For my control arm, I enrolled 20 dogs of any age, sex, non-Doberman Pinscher breeds and non-Greyhound breeds, with a normal hemogram, biochem, and coagulation times. So my study was a prospective observational cohort study, and this just shows the sort of study design of my patients. Essentially, they'd been envenomed at some point prior to presentation. Then on presentation, they were enrolled into my study. We took typical markers of hospitalization, such as duration of hospitalization, survival, and cost of treatment. And then we collected blood in EDTA, plain clotting tubes, and citrate tubes. And then we gave them antivenom and allotted that time 0 to time the future collections of blood. Then we collected more blood at time points 3, 12, and 24 hours after antivenom, just in citrate tubes. We immediately sampled the EDTA for platelet count, and the plain clotting tubes and citrate tubes were centrifuged, separated and aliquoted, and then stored at minus 80 degrees for batch analysis later on, no longer than 13 months. So for my sample analysis, for the venom concentrations, we used a capture sandwich ELISA technique with alpaca antibodies at the Padula Serum Laboratories. That had a limit detection of 0.15 nanograms per mil. For fibrinogen, we used the Klaus method, which had a limit detection of 0.4 grams per litre. And for factor activity, we used human factor-deprived plasma and compared it to a canine calibration curve with our Stego device. And for PT and APTT, we also used a Stego device, and that had a sort of out of range of greater than 120 and 180. For our data, we collected the data and stored it online on REDCap, the online database. And for the current statistics that we have, we've used SPSS and R. So my study ran over 2 snake bite periods. I think we had about 70 snakes that came in through the door, snake bites that came in through the door over that period, but was only able to enroll 19 dogs. And then we had to exclude 8 dogs as they were negative for tiger snake venom on post-collection analysis, which left 11 cases to analyze. Of these cases, we had about 80% purebred, almost 50-50 male and female. Most dogs received 1 to 2 vials, but 1 dog did receive 3 vials of antivenom. None of them required mechanical ventilation, and all the patients survived. So the following graphs basically show the factor activity over time since envenomation. The grey bars are the 95% tolerance interval, which is a predicted reference interval for the population. And at the bottom, I've got the median factor activity on presentation with a 95% confidence interval compared to my control values. So as you can see, fibrinogen at presentation was much lower compared to the control levels. In fact, it was at the lower detection limit. That's why the confidence interval is so small. And as you can see on the graph, showing an overall view of the activity and time relationship, it does look like there's progression towards normal over time. Similar things can be said for factors 5, 8, 10 and 2 in that order. So factors 5 and 8 were much more affected, and factors 10 and 2 were mildly affected, but both were sort of different to controls with progression towards normal over time as well. Factor 7 had no real effect, so this remained normal throughout the study period. And just as some preliminary data at the moment, what I've done is shown the control on the left. So these are box plots with median, interquartile ranges, and maximum minimums. And on the left is the control values. And you can see that this is fibrinogen at time point 0, 3, 12, and 24. And at 0, 3, and 12 hours after antivenom, the fibrinogen was fairly different to control, with return to control values by about 24 hours. And factor 5 was different at time point 0 and 3 hours after antivenom, with return to controls by about 12 hours. And same with 8. So, seems like coagulation factor activity is, except for factor 7, is different to control levels and will return to control levels by about 12 to 24 hours after antivenom. So it appears that this is a fairly self-limiting syndrome, similar to what we see in people. So it begs the question of whether we do need to monitor coagulation times or not in these patients. But we also know now that if there is an ongoing coagulopathy after 24 hours, that there might be another disease process going on, or the patient might be developing DIC, for example. And comparing my data to the literature was quite interesting. So in this plot, we've got the factor activity of dogs in red and in people in black. And you can see there's a similar trend of the severity of factor deficiency. So factor 5 was much more affected compared to 10. But what's interesting is, particularly in factor 8, the dogs did not have such a dramatic decrease in factor activity compared to people, which may explain why our patients are less likely to have hemorrhage, whereas in people, intracranial hemorrhage is usually the cause of death in envenomation. We know, though, that dogs have a higher factor 5 and factor 8 activity compared to people, so it might almost be a protective mechanism in our patients, which then begs the question why some dogs bleed and some dogs don't. To address that, I guess we wanted to look at dogs with haemophilia as sort of single factor deficiencies, and I used haemophilia A, or factor 8 deficiency, as an example. And this is usually classed on severity based on the factor activity itself. So a mild haemophiliac had less than 20% activity and a severe had less than 1% activity. But the interesting thing is the tendency to bleed in these patients is not associated with the severity of the factor deficiency anyway, which begs the question, perhaps there are other sort of factors in play, and we are just talking about one factor in haemophiliacs, and in VIC, there is sort of more than one factor deficiency. So we also know, though, that if you have two factors that are 75% in activity, that you can get prolongations in PT and APTT. But how does this sort of translate clinically? And in people, they have sort of familial multiple coagulation factor deficiencies. And one example is FMCFD1, which is a deficiency in both factor 5 and 8. And once again, though, these people with FMCFD1 were more likely to, or just as likely to bleed as individuals that had a factor deficiency of just 5 or just 8. So it still leaves a question open about why some people bleed and some dogs bleed and some don't. Could it be that the other factors are more important? Could there be patient factors involved, or even venom factors involved that might sort of predispose these patients? So do we treat VIC? A randomized controlled study looking at the administration of fresh frozen plasma in VIC showed that it did hasten recovery of VIC itself, but it did not affect any patient-centered outcomes, such as survival to discharge or duration of hospitalization. In fact, in a canine experimental model of brown snake envenomation, those dogs given fresh frozen plasma had persistent afibrinogenemia compared to those not given plasma. I mean, potentially the provision of further factors might actually feed this coagulopathy and sort of perpetuate the procoagulant. At the moment, I guess the suggestion is if there's clinical bleeding, then yes, I think factor replacement is required. Unfortunately, at this point in time, this presentation only represents part of my data analysis, so I am still ongoing with my inferential statistics, so we'll know a little bit more later on. And the other thing we are going to be looking at is if there's a correlation between factor activity troughs and severity of clinical signs, as per our sort of clinical assessment, clinical severity assessment. So, all in all, in our patients, it seems that we have absent fibrinogen after being bitten by a snake, low to absent factors 5 and 8, and partial depletions in factor 2 and 10 with rapid recovery, similar to our human counterparts. So going forward, I guess one of the big limitations of my study was the very small sample size, but given the stability of the factors, it might lend itself to multi-centered studies. And further studies may want to look at brown snakes in particular, particularly brown snakes, or sort of combining them all as one. I think more research looking at factors 5 and 8 in particular, as they were the ones that were most affected, and also fibrinogen. We know that fibrinogen sort of plays a key role in coagulation. So, and I think in some studies, if you actually just administer fibrinogen, that's going to help with the coagulopathy anyway. In regards to why some dogs bleed and some dogs don't, as different schools of thought, it could be patient factors. It could also be that some snake venom actually contains a hemorrhagin, which predisposes them to bleed. I think in that Lyon paper, they suspected some patients had pulmonary thromboembolism, so it could be a few other things. And I think in the future, it might be worthwhile looking at the correlation between snake venom concentration and severity of clinical signs, factor activity troughs, and see if there's any correlation between there. So I'd like to thank my supervisors, Dr. Manu, Natalie Cortman, one of our clinical pathologists at UniMel, and Des Hughes as well. Andrew Woodward, who's still helping me with my statistics at the moment. Andrew Padula for helping with the sort of tiger snake venom quantification, and Ken Winkle for being part of my advisory committee. You can scan the code and there's a PDF for more information if you need.